In this presentation, we will highlight the differences in clinical manifestations of different aortic aneurysmal syndromes, including Marfan syndrome, Ehlers-Danlos syndrome, and Loeys-Dietz syndrome. It is well known that genetics have an important contribution to the pathogenesis of thoracic aortic aneurysm. This is evidenced by the fact that 1 out of 5 patients with thoracic aortic aneurysm and dissection does have a positive family history, as such indicating a strong genetic contribution. Over the last decades, dozens of genes have been identified underlying this condition. At present, these genes account for both syndromic and non-syndromic forms. We can largely group these genes together into 3 subcategories. First, genes encoding for components of the extracellular matrix, for example, fibrillin 1 in Marfan syndrome or COL3A1 in Vascular Ehlers-Danlos syndrome. Second, genes encoding for components of the contractile apparatus of the vascular smooth muscle cell. For example, ACTA2 is the most common one, and most of these genes account for non-syndromic familial thoracic aortic aneurysm and dissection. And finally, the third group involves genes coding for components of the TGF-beta signaling pathway, and this pathway is important in the pathogenesis of Loeys-Dietz syndrome. In this presentation, we will focus on syndromic forms of thoracic aortic aneurysms. In this group of diseases, multisystemic involvement is typical. In addition to the aneurysm and dissections of arteries and aortas, multiple other organ systems are involved. Most prominently, the eye, for example, lens dislocation in Marfan syndrome, the joints and skeleton with overgrowth characterized by pectus deformities, scoliosis and arachnodactyly, and joint hypermobility, and finally the skin with skin hyperextensibility and skin striae. In this presentation, we will focus on 3 of the major groups belonging to the wide spectrum of connective tissue diseases with aortic and arterial involvement. First, I will discuss Marfan syndrome. Marfan syndrome is an autosomal dominant connective tissue disorder caused by mutations in a gene called FBN1. FBN1 encodes for fibrillin 1. Fibrillin 1 is an important extracellular matrix protein present in the aortic wall, the eye, and skeletal system. Although the condition is autosomal dominant, it is important to know that 1 out of 3 patients with Marfan syndrome is the consequence of a de novo mutation. So the absence of a family history does not exclude this diagnosis. The current clinical diagnosis decision-making is based on the revised Marfan nosology defined in 2010. This nosology is based on clinical findings in 3 main organ systems. First, in the skeleton, we note overgrowth that can be seen by long fingers or arachnodactyly, tall stature, overgrowth of the ribs leading to pectus deformities, and also spinal deformities leading to scoliosis. Second, 60% of all Marfan patients do have lens dislocation or ectopia lentis, which can only be formally diagnosed with a slit lamp exam. Finally, the third organ system, being the cardiovascular system, is characterized by valve insufficiencies, for example, the aortic valve and the mitral valve, but most prominently by a dilatation of the aorta in Marfan syndrome, typically at the sinuses of Valsalva. The latter is the most life-threatening symptom that can lead to aortic dissection and death if undiagnosed. In the current clinical diagnostic criteria, a defined set of criteria has been defined to make a diagnosis of Marfan syndrome in the absence of a family history. 4 rules can lead to the diagnosis. First, the presence of aortic aneurysm dissection with ectopia lentis is sufficient to make a diagnosis of Marfan syndrome. Second, the presence of aortic dilatation in association with a pathogenic fibrillin 1 mutation. Third, the association of aortic aneurysm and a systemic score of 7 or more points. And finally, in the case of ectopia lentis, it needs to be associated with a fibrillin 1 mutation that has been previously associated with aortic disease. A similar set of rules has been defined in the presence of family history. What is now this Marfan systemic score? It is a score in which different symptoms and signs do get a different weight according to their specificity for Marfan syndrome. The presence of arachnodactyly, evidenced by wrist and thumb sign, leads to a score of 3 points. 2 points can be assigned to pectus carinatum deformity, flat feet with medial displacement of the medial malleolus, protrusio acetabuli, pneumothorax, or dural ectasia. One point is assigned to either of the following features. First, a reduced upper to lower segment ratio and an increased arm span to height ratio in the absence of severe scoliosis, scoliosis or thoracolumbar kyphosis, reduced elbow extension, typical facial features, skin striae, myopia of more than 3 diopters, and mitral valve prolapse. If all these signs and symptoms are scored, a total of 20 points can be obtained, and the systemic score is fulfilled when 7 or more points are obtained. The second disease to be discussed is Loeys-Dietz syndrome. Loeys-Dietz syndrome was initially described as a syndrome characterized by a typical triad of hypertelorism or widely spaced eyes, cleft palate or bifid uvula, and a bifid uvula should be considered as a minimal expression of cleft palate, in association with arterial tortuosity, aortic aneurysm, and dissection. Although Loeys-Dietz syndrome has many features in common with Marfan syndrome, such as scoliosis, pectus deformity, arachnodactyly, and aortic root aneurysm, it also has many unique features that can be used to distinguish both conditions. These unique features include hypertelorism, or widely spaced eyes, cleft palate and bifid uvula, craniosynostosis, or premature skull fusion, clubfoot deformity, congenital heart disease such as patent ductus arteriosus, bicuspid aortic valve atrial septal defect, the presence of arterial tortuosity with widespread aneurysms throughout the arterial tree, and rupture and death at young age and at smaller diameters than usually seen in Marfan syndrome. Since the initial discovery of TGF-beta receptor 1 and 2 gene underlying Loeys-Dietz syndrome, a wide spectrum of disease has been recognized. At present, we see different clinical phenotypes at the extreme ends of the spectrum. In isolated patients with more outward and systemic features of the typical LDS spectrum, for example, cleft palate, hypertelorism, craniosynostosis, we usually observe also a more severe cardiovascular involvement, with earlier need for surgery and aortic dissections occurring at smaller diameters. At the other end of the spectrum, we do recognize familial cases with less outward systemic features that belong more into the non-syndromic familial thoracic aortic aneurysm spectrum. It is, however, important to realize that the identical TGF-beta receptor 1 and 2 mutations have been seen in either typical LDS patients or patients with less or no systemic features. The explanation for the diversity is probably related to the existence of genetic modifiers. Secondly, it's also important to know that a mildly affected parent with a TGF-beta receptor 1 or 2 mutation can have a severely affected child. Although initially we identified only mutations in TGF-beta receptor 1 and 2, the LDS spectrum has now been expanded along the complete arterial tree, TGF-beta signaling pathway. Mutations have been described in the cytokines, respectively TGF-beta 2 and 3, the receptors, TGF-beta receptor 1 and 2, and the first downstream effectors SMAD2 and 3. Mutations in SMAD3 were initially associated with a condition called aortic aneurysm with osteoarthritis, but due to the significant overlap with Loeys-Dietz syndrome, it is now recognized as LDS type 3. In the past, it was shown that deficiency of fibrillin 1 leads to a dysregulation of the TGF-beta signaling. And the implication of all the components of the TGF-beta signaling pathway further reinforce the important role of TGF-beta signaling in aortic aneurysm formation. Although the complete pathway is still poorly understood, we do observe a upregulation of the TGF-beta signaling in the aortic wall, both in Marfan syndrome and Loeys-Dietz syndrome. In Loeys-Dietz syndrome, this has been called a paradoxical increase, as the mutations in the different genes are predicted to lead to a loss of function, but in the aortic wall tissues, we observe a significant increase signature for TGF-beta signaling. Within the LDS phenotypical spectrum, preliminary data suggests there is also a spectrum of disease severity. The most severe presentations with multiple systemic features, young age of onset, and dissection at small diameters seems to be more frequent in the TGF-beta receptor 1 and 2 and SMAD3 related mutations. Families with mutations in TGF-beta 2, SMAD2, and more recently TGF-beta 3 seem to have a milder expression with examples of mutation carriers that do never develop aortic disease, so-called non-penetrant individuals. When we look at the individual phenotypical characteristics of the patients within the LDS spectrum, we see a lot of overlap of the existing phenotypical traits. One definitely distinguishing feature between Marfan syndrome and LDS is the presence of ectopia lentis, which seems to be uniquely associated with Marfan syndrome. The clinical comparison of Marfan syndrome and Loeys-Dietz syndrome has revealed some important lessons from the natural history. First of all, in Loeys-Dietz syndrome, dissections occur at smaller diameters and younger ages than in Marfan syndrome. This implies the need for earlier consideration of aortic surgery, and importantly, this surgery has a better prognosis than in Vascular Ehlers-Danlos syndrome. Secondly, because the arterial aneurysms and dissections do not occur predominantly at the sinus of Valsalva, as in Marfan syndrome, but can happen throughout the arterial tree, a more complete imaging strategy with CT scan or MR scan from the arterial tree from head to pelvis is indicated. For those of you who want to learn more about the management guidelines currently established for the Loeys-Dietz syndrome, we refer you to this open access article in the journal Genetics in Medicine of 2014. The final group of diseases that we will discuss is the heterogeneous group of Ehlers-Danlos syndrome. According to the most recent nosology, 13 common subtypes of Ehlers-Danlos syndrome have been described. These subtypes are briefly discussed in the manuscript. For each subtype, major and minor criteria are proposed within the nosology. The minor criteria are less specific, whereas the major criteria involve features that occur in the majority of patients with a specific subtype. we will focus on a number of Ehlers-Danlos syndromes with prominent aortic and vascular involvement. The first one is the Vascular Ehlers-Danlos syndrome, the former type 4, which is autosomal dominant, but in 50% of the patients the consequence of a de novo mutation. It is caused by a deficiency of type 3 collagen and presents in the clinic with aneurysms and dissections, typically of middle-sized arteries, but also with intestinal and uterine ruptures. The skin is not hyperextensible, but rather thin and translucent, and there is also some evidence for specific small joint hypermobility. In the past, diagnosis was made based on biochemistry, but currently most labs go for direct sequencing of the COL3A1 gene coding for the alpha-1 chain of type 3 collagen. A more recently described vascular type of Ehlers-Danlos syndrome is autosomal dominant and caused by specific arginine to cysteine substitutions in the triple helix of the alpha-1 chain of collagen 1. Aneurysms in those patients typically occur in the infrarenal aortic and infrarenal arteries. The disease can be associated with osteopenia, skin hyperextensibility, and variable joint hypermobility. Diagnosis is made by direct sequencing of COL1A1 gene. A second EDS type with cardiac and valvular involvement is called the Cardiac-valvular Ehlers-Danlos syndrome. It is autosomal recessive and caused by a complete deficiency of a COL1 alpha-2 chain. It usually presents with multiple severe valvular insufficiency and also occasionally with aortic dilatation, and the patients can present in childhood with joint hypermobility and skin hyperextensibility. Diagnosis can be confirmed by direct sequencing of the COL1A2 gene. A final and last form of Ehlers-Danlos syndrome is the Kyphoscoliotic type of Ehlers-Danlos syndrome, which is the former type 6A. It is also autosomal recessive and is caused by a deficiency of an enzyme called lysyl hydroxylase, which is encoded by PLOT1 gene. In this condition, children early on present with kyphoscoliosis, hypotonia, and scleral fragility, and can develop aortic and middle-sized artery dissections at later age. Diagnosis can be suspected by a biochemical analysis of collagen metabolites, but is confirmed unequivocally by mutations in the PLOT1 gene. Interestingly, these patients can also have a Marfanoid habitus with scoliosis, hernia, and joint hypermobility.